Hello guys, welcome to my 10. So in this video we are going to discuss about the anatomy of the foramen epiploicum, what are its boundaries, and also we look at the clinical significance of the foramen epiploicum. So foramen epiploicum, it is also called as the foramen of Winslow. Foramen of Winslow. So the foramen epiploicum is it's a vertical slit through which the lesser sac of the peritoneum communicates with the greater sac. We have the greater sac here, and then we have the lesser sac. So the communication between the greater sac and the lesser sac, this communication nothing but as the foramen epiploicum. So it is situated behind the right free margin of the lesser omentum at the level of the T12 vertebra. So what are the boundaries of the foramen epiploicum? Coming to the boundaries, here we have the foramen epiploicum, and then coming to its boundaries, anteriorly it is bounded by the right free border of the lesser omentum. So anteriorly we have the right free border of the lesser omentum. Along the, it also contains the bile duct, the hepatic artery, and then the portal vein. So the bile duct, hepatic artery, and the portal vein, these form the porta hepatis, right? So this forms the anterior border of the foramen epiploicum. So what contains the posterior border? Posterior border contains the inferior vena cava and the inferior vena cava, and the right suprarenal gland will form the posterior border. And superiorly we have the caudate process of the caudate lobe of the liver. Superiorly we have the caudate lobe of the liver, and then inferiorly we have the first part of the duodenum, and also the transverse of the hepatic artery. So these are the boundaries. This is the anterior, this is the posterior, this is the superior, and then this is the inferior borders. Anteriorly it is bounded by the porta hepatis and the right free margin of the lesser omentum, which contains the bile duct, hepatic artery, and the portal vein. And then posteriorly it is bounded by the inferior vena cava and the right suprarenal gland. And superiorly we have the caudate lobe of the liver and inferiorly we have the first part of the duodenum and also the transverse lining of the hepatic artery. So these are the boundaries of the foramen epiploicum. Now let's discuss about clinical significance of it. So coming to the clinical significance, firstly we will discussing about the internal hernia. So what happens? Sometimes the loop of the small intestine, it will herniate into the lesser sac through the foramen epiploicum, which produces an internal hernia. So it goes from the lesser sac to the foramen epiploicum. So this produces an internal hernia. So what if this internal hernia is strangulated? It is stuck. So if this hernia, if it is strangulated, it cannot be reduced by cutting any of the important boundaries. We cannot cut any of the boundaries to destrangulate it. So basically what happens? However, it can be reduced by aspirating the gut contents. We will aspirate the gut contents, and then we will push the herniated loop out of the lesser sac by inserting our index finger, and through it into the anterior two layers of the greater omentum. We'll insert the index finger, and then firstly we'll aspirate the gut contents. We'll insert the index finger, and then we'll extract the loop of the internal hernia if it is strangulated. Then secondly we'll be discussing is the what if during cholecystectomy, if hemorrhage occurs. During cholecystectomy, if there is hemorrhage during cholecystectomy, then that hemorrhage will be due to the damage to the cystic artery. So cystic artery can be nicked during cholecystectomy. So if the cystic artery is torn during cholecystectomy, what the surgeon should do is that the surgeon can stop this hemorrhage by compressing the hepatic pedicel. They need to compress the hepatic pedicel. Compress the hepatic pedicel, because the hepatic pedicel contains the portal vein, hepatic artery, and the bile duct. So by constricting the hepatic artery, the common hepatic artery, they will block the cystic artery, thus they can reduce the hemorrhage. So this was a video about the foramen epiploicum and the clinical significance. So lastly we will discuss about the rectouterine pouch or the pouch of Douglas. So this is a pouch of the peritoneum. It's a pouch of peritoneum, which is situated between the rectum and the uterus. We have the uterus here, and then this is the rectum. So this space between the rectum and the uterus is the rectouterine pouch or the pouch of Douglas. So it is the most dependent part of the peritoneal cavity. Most dependent part of the peritoneal cavity in the upright position. So in the supine position, the most dependent part of the pelvic cavity. In supine position, it is most dependent part of the pelvic cavity, and in the upright position, it is most dependent part of the abdominal cavity. So what are the boundaries of the rectouterine pouch? Anteriorly we have the uterus and also the upper 1/3 of the vagina, and posteriorly we have the rectum, and inferiorly we have the rectovaginal fold, which is 5.5 centimeters in length. So this is about the rectouterine pouch and its boundaries. Coming to its clinical significance. So the rectouterine pouch is the most dependent part of the peritoneal cavity below the pelvic rim. So the below the pelvic rim, the pus tends to collect here. Pus will tend to collect here. So the pus can be drained either through the rectum or also through the posterior fornix of the vagina. So that is known as the posterior colpotomy. So either we can drain it through the rectum or else we can drain it through the posterior fornix of the vagina. So this was about the rectouterine pouch or the pouch of Douglas. If you like the video, make sure to subscribe and hit the like button, and also please share it to your other friends who are finding anatomy difficult. Thank you so much.